Hi, hello and welcome to my channel Easycology with Bud. Today we will discuss about the pharmacology of oral hypoglycemic drugs in a glance. If you want the detailed video or detailed theoretical explanation for the same chapter, I suggest you watch the detailed video. In the description box I have put the link. So let us move into the chapter. Now you can see this is the beta cell. Okay, so on top of the beta cell we have a channel called as the potassium ATP channel, that is the potassium sensitive ATP channel. We have a calcium channel. We also have a incretin receptor. So let us move to the first category, that is the sulfonylurea. So sulfonylureas and second category meglitinides are going to block one unit called the SUR1 unit, which is present in the potassium ATP channel, potassium sensitive ATP channel. So once this particular subunit is blocked, this entire channel, potassium channel, will be blocked. When the potassium channel is blocked, there a depolarization of the cell is going to take place, right? Because potassium is not coming inside or going outside, there is depolarization of the cell. Because of that, the calcium channel is going to activate and the calcium is going to come inside. Now we know that since calcium is going to come inside, there will be exocytosis of the vesicles, so insulin is going to release. So that is the first and second category, sulfonylureas and meglitinides. They are going to act both in the same site, that is the SUR1. But the difference between the sulfonylurea and meglitinide is that meglitinides are going to be rapid onset and short duration of action drugs. So they are going to be only used for the postprandial glucose. Third category is the GLP-1 receptor agonists. Okay, so this is going to be the incretin receptor, and once when GLP is going to bind to it, it is going to be an alpha type of GPCR. So GS alpha type is going to activate adenyl cyclase, which will convert ATP to cyclic AMP. We know that cyclic AMP can activate the calcium, release the calcium. So again there will be exocytosis of insulin and then the insulin will be released. So this is the function of GLP when it binds to the GLP, the incretin receptor. So now if we are going to have incretin mimetics, that is exenatide or liraglutide, then they are also going to have same function. Their function is by activating adenyl cyclase, cyclic AMP, and release of calcium and release of insulin. Fourth one is DPP4 inhibitors. DPP4 is an enzyme which will degrade the incretins like GLP-1 and GIP. So if it is going to be degraded, then insulin will not release by this mechanism, right? So we are going to inhibit the enzyme that degrades incretins. Therefore, this entire mechanism will be restored. So that is DPP4 inhibitors. So the drugs are all the gliptins: linagliptin, sitagliptin, saxagliptin, aldogliptin. Okay. Next is the alpha glucosidase inhibitors. So alpha glucosidase is an enzyme which is going to convert polysaccharides to glucose. Now if this enzyme is going to be inhibited, then glucose will not be formed. So here we have drugs like voglibose, acarbose. Next we have diazolidine and bigonides, which are insulin sensitizers. That is, they are going to improve the way the cell is going to respond to insulin. That is, it will put the glucose in the peripheral tissues or improve the peripheral utilization of the glucose, right? So thiazolidine is a PPAR gamma activator, which is a nuclear receptor. So it is going to increase the genes, insulin responsive genes, and also it will predominantly act in the fatty acid or the adipocytes, right? So because of that, they are going to cause insulin sensitization. Similarly, bigonides is going to activate AMPK, and therefore it is going to improve the peripheral utilization of the glucose and cause the insulin sensitization. Okay, so we can overcome insulin resistance by these mechanisms. And the final one is the SGL2 inhibitors. Okay, so generally what happens, the glucose will be filtered from the glomerulus. It will go to the proximal convoluted tubule, from where it will be reabsorbed to blood with the help of the transporter SGLT2. But we do not want the glucose in circulation, right? So we have to inhibit this transporter. Once we inhibit this transporter, automatically the glucose will be excreted through urine and glycosuria will be formed. So that is SGL2 inhibitors. So here we have drugs like gliflozin, okay, dapagliflozin. So all the gliflozins will come under this category. So these are the drugs. Sulfonylureas, we have tolbutamide, glimepiride, glibenclamide, glipizide, meglitinides, repaglinide, natglinide, and GLP receptor agonists, exenatide, liraglutide, DPP4 inhibitors, sitagliptin, linagliptin, A-carbose inhibitors, A-carbose, voglibose, thiazolidinediones, rosiglitazone, pioglitazone, biguanides, metformin, and SGL2 inhibitors. Okay, gliflozins, dapagliflozin. So this is the short mechanism of action with the classification. I hope you understood this. Thank you.